In HIV research and in treatment, the immune system, the CD4 cell, is an important measure of where you are in your disease. Now, the CD4 cell is part of your body's immune system that helps fight infection. So we measure that, and we don't start treatment straight away. The standard of care at the moment is that if somebody's CD4 is below 350, we start them on treatment. So that's not typical of most diseases, but for HIV that is the standard of care. And so we were interested in we recruited men and women who were HIV infected who had CD4 cells more than 500, so were not yet eligible for treatment. And then we followed them for up to 3 years to see how many of them would reach that threshold for starting treatment while they were being followed up. And so we were regularly measuring their CD4 count. They are asked to check their CD4 count every 6 months, and some come sometimes a little earlier, sometimes a little after. So in terms of HIV disease progression, we believe that's occurring in general when the CD4 numbers are going down. And so we were interested in seeing how quickly men and women progress from being above 500 to below 350. And our research was the first study to find that among men in this rural African setting in KwaZulu-Natal, South Africa, were reaching that threshold and needing to start treatment within, on average, 12 months, while women were taking almost 3 years on average to reach that same threshold. Well, it matters because we want to get people onto treatment as soon as it is the right time to get them on treatment. And so if men, or in particular, given that they might reach that threshold within 12 months, if they don't come in a timely fashion to have another CD4 check, then by the time they come again, they may be actually lower than the threshold that they should be at. And so we may have missed the earliest opportunity to start them on treatment. And so we believe that this study suggests that we need to actually be more active in making sure that men learn their HIV status early, so with regular HIV testing, that they also come into care early, and that they stay in care and come back for this regular testing. We meet women more often in clinics, and for other reasons they come with childcare or for their own care more readily than men do. And so we may need particular strategies to try and actually approach men in the community and trying to get them more regularly into the clinics. The subtype of the virus of HIV that's here in the UK and in Europe is actually slightly different than the subtype that we have in Africa, and therefore there may even be differences that are also contributing to this difference. So we would not immediately take the information from Africa and then apply it in this context. The population of men who become infected in the UK context is also very different than the population of men who become HIV infected in the African setting. The one additional comment to make is that this is an area that is very fast moving in terms of when we should start treating people. And as we move to starting everybody who is HIV infected as soon as they're diagnosed, that will also have an impact on their risk of transmitting to other people, because treatment has an opportunity to reduce the amount of virus in an individual's body, and therefore reduce their risk of transmission to another person. And so we hope really to see an impact of treatment, not just continuing to improve health of individuals who are infected, but also we hope that there will be an impact